I'm pleased to have Dinesh Thavendiranathan join us from the University Health Network to talk about the emerging epidemic of cancer and heart failure. Dinesh is the lead of the Ted Rogers program in Cardiotoxicity Prevention. He's a cardiologist, Peter Munk Center, and the clinical researcher at Toronto General Research Institute. He is a fantastic colleague and someone who is, when we talk about rising star, someone who really has distinguished himself as an independent investigator within the first 3 years of his faculty appointment. So, Dinesh, it's great to have you here and to talk about such an important subject.
Thank you very much, Mike, for that kind introduction. I'd like to start off by thanking the organizing committee for an opportunity to speak about cancer and heart disease. I have no relevant disclosures. Okay, my objectives today are to discuss the epidemiology of cancer and cardiac disease, to discuss the burden of cardiac disease in cancer patients with an emphasis on shared risk factors, the impact of the cancer treatment directly on the heart, the cardiovascular care gap. I'll then focus on prevention of heart failure in cancer patients and wrap up by discussing some of the research priorities in this area. I don't think I have to convince this audience that heart disease and cancer are the top two causes of mortality in men and women. This is the case in high-income countries, but also in the middle-income countries, and these two diseases are an important cause of mortality in low-income countries as well. But if you project forward 15 years to 2030, these two diseases will be the most common cause of mortality globally. If we change our focus to cancer, one of the things that we realize is that the incidence of cancer has pretty much remained the same or slightly increased in women. But fortunately, over the past 30 years, there has been a significant reduction in cancer-related mortality in men and women. As a consequence, in 2009 itself, there are over 800,000 Canadians who are cancer survivors. And in the United States, there are over 10 million individuals who are cancer survivors. It's also projected, if you again look forward over the next 10 to 15 years, the average annual number of new cancers is estimated to increase by about 80%, which means globally we'll have millions of patients who are cancer survivors. Unfortunately, patients who have cancer are also at a higher risk of cardiovascular disease. And we'll look at this by focusing on two important populations. One is pediatric cancer survivors, and the other is breast cancer survivors. There's been a lot of work done in the United States with the St. Jude Life cohort, which has followed a set of patients who are pediatric cancer survivors over the time, and I've looked at various things in these patients, including cardiovascular risk. In their most recent publication just a few months back, they demonstrated a high prevalence of cardiovascular disease in these childhood cancer survivors. And this includes cardiomyopathy, coronary artery disease, valvular heart disease, as well as conduction abnormalities. The development of cardiovascular disease in this patient is not benign, as nicely demonstrated in this British-French population, where if you're a childhood cancer survivor, your risk of cardiac death is significantly higher than expected. The same data is also seen in the US population. If you follow cancer survivors, childhood cancer survivors over time, your mortality rate, which is a blue line, is significantly higher than the US population. What's also interesting is if you look at the cost of mortality over time, what you'll see is initially over the first 25 years, cancer is the primary cause of death. But by 25 years afterwards, cardiovascular disease becomes the most important cause. But it's important to realize that these children develop their cancer at the age of 5. So 25 years later, they're still in their mid-30s and early 40s when cardiovascular disease becomes the primary cause of morbidity and mortality. The same is seen in the breast cancer population. This is some work from Ontario. We looked at 18,500 women who were diagnosed with breast cancer between 2007 and 2012 and received cancer therapy. We compared these women to 92,000 age-matched Ontario residents and looked at the incidence of important cardiovascular disease defined as congestive heart failure and cardiovascular mortality. We looked at the groups in two different categories, those below the age of 65 and those above the age of 65. If you look at the patients below the age of 65, the blue lines are patients who are cancer survivors. The yellow line are the matched healthy Ontario residents. You see that the risk in these patients are about fourfold higher than the matched population. The absolute risk, as suspected, is significantly higher in the older population, about 8.5% by 5 years of follow-up, but the relative increase compared to the yellow line in the older population is smaller, which means many younger patients who have survived cancer are at a risk of heart failure and cardiovascular mortality. There's been nice work done by Dr. Hussam Abdul Qadir, who's doing his PhD with our group, and he's looked at cardiovascular hospitalization in women diagnosed with breast cancer between 1998 and 2012. He has nicely shown in 100,000 patients over about a 6.5-year follow-up, there's a 10% incidence of cardiovascular hospitalization. And the reason for hospitalization is variable and depends and includes ischemic heart disease, congestive heart failure, as well as rhythm abnormalities. The development of heart disease is again not benign in this population. If you again look at the older population, cancer remains an important cause of mortality, but cardiovascular disease is the next most important competing risk. If you look at patients who had pre-existing cardiovascular disease, then cardiovascular mortality is the primary cause of death in these cancer survivors. Particularly, the development of congestive heart failure appears to portend a poor prognosis, and this is some work that's now about 15 years old, where patients with different forms of cardiomyopathy were followed over time. And what you see is that patients who have anthracycline-mediated cardiotoxicity had much worse prognosis here than the two more common causes of cardiomyopathy we've seen in cardiology practice, which is ischemic and idiopathic cardiomyopathy. When we looked at our UHN heart failure database, these were patients who received VADs and heart transplant. Approximately 4% of the patients who had received this advanced cardiac support had anthracycline-induced cardiomyopathy. So why are these patients who have survived cancer at a higher risk of cardiovascular disease and cardiovascular mortality? And I'd like to propose 3 different mechanisms. The first is shared risk factors for cancer and cardiac disease, similar to what you heard in diabetes. This means that a patient who has developed cancer is already intrinsically at a higher risk of developing cardiovascular disease or already has subclinical cardiovascular disease, which manifests itself subsequently with the toxic therapies that we use. So let's look at some of these shared risk factors. So there are many shared risk factors. I'll focus on 3. This includes tobacco use, unhealthy diets, and physical inactivity. Let's look at each one at a time. Cancer and heart disease account for the 2 to 3-fold increase in death due to smoking. Fortunately, in North America, there has been a significant reduction in the incidence of smoking. But the tobacco industries have gotten smart, and they have been targeting developing countries with the rising global consumption of smoking. And this has implications for the global rates of cardiac disease and cancer. The second is obesity. Greater than a third of our world's population is obese. 1 in 5 Canadian adult is obese, and 1 in 8 Canadian adult is also obese. And obesity, as we know, is an increased risk factor for cardiovascular disease through multiple different mechanisms. And each 1 kilogram per meter squared increase in your BMI is associated with a 21% increased risk of cancer. And obesity has been associated with multiple different cancers. Obesity is a risk factor also for cancer death, with the population attributable risk of approximately 14% in men and 20% in women. The higher risk in women is perhaps due to estradiol production and increased prevalence of estrogen-sensitive tumors. There are also pro-inflammatory cytokines which have been involved in promotion of cancer growth and metastasis. The third is sedentary behavior. Exercise reduces coronary heart disease mortality and heart failure. This is something that we know, and there seems to be a dose-response relationship with more activity resulting in less cardiovascular mortality and heart failure. We have seen a similar trend also with cancer as well, with a direct relationship or an increasing relationship with more activity and a reduction in cancer incidence as well as cancer-related mortality. And there's data that suggests each 1% reduction in mortality, there's a 1% reduction in mortality for every 15 minutes increase in your daily physical activity. So how are Canadians doing? If you look at Canadians over the past 30 years, there's been a significant increase in obesity, and it's projected by 2030, 1 in 3 Canadians would be obese. There's also poor physical activity levels in Canadians. If you look at patients or individuals over the about age of 25, approximately 50% of our populations are not engaged in adequate physical activity. The second risk factor, the second reason why patients with cancer are probably at a higher risk of cardiovascular disease, is the direct impact of cancer treatment on the myocardium and the conduction system, the pericardium, and the valves. Many of the agents that we use to treat some of the common cancers today, breast cancer, hematological malignancies, are associated with the risk of cardiotoxicity. The agents that we use, such as anthracyclines, alkylating agents, tyrosine kinase inhibitors, and antimetabolites, all are associated with a high risk of heart failure and other forms of cardiac injury, such as ischemic heart disease, coronary artery disease, as well as hypertension. And remember, many patients receiving cancer treatment receive more than one drug, increasing the synergistic impact of these drugs on cardiomyocytes and increasing the risk of heart failure and other cardiovascular complications. There have been multiple mechanisms that have been suggested by which these agents have an impact on the myocytes, and I won't go into details here, but these result in the morphological phenotypes that we see in our clinical practice: left ventricular dysfunction, heart failure, atherosclerosis, and hypertension. The next is that there seems to be a discrepancy between the rates of cardiac dysfunction in adjuvant clinical trials, trials in which these drugs were approved for prevention or for treatment of cancer, and the risks that we see in routine clinical practice. This is our data, again, looking at approximately 18,000 patients in Ontario. These are women with breast cancer who were treated with different therapies. We looked at the risk of heart failure and cardiovascular mortality. With anthracyclines alone, the risk is about 1.8%. With trastuzumab, which is used in HER2-positive cancers, the risk is about 5%. And when you combine these two drugs, the risks increase significantly to over 6%. And this is comparable to clinical trial data, where the risk is perhaps between 0 to 3%. And the reason for this discrepancy is that when these drugs are approved, we are likely using it in higher risk populations, higher cardiovascular risk population, increasing the risk of cardiovascular complications. We also cannot forget radiation therapy, and radiation therapy is commonly used in many cancers, pediatric cancers, as well as, for example, breast cancer. There's been a lot of data showing a direct relationship between the mean dose to the heart and the incidence of major coronary events. The third reason why patients with cancer are at a higher risk of cardiovascular disease is that there seems to be a care gap. There seems to be a lack of adequate cardiovascular care in patients with cancer. And this may be perhaps because the general thought amongst practitioners is that you've had cancer, you're probably going to die from your cancer. Why worry about cardiovascular risk prevention? That may be the reason. And this is nicely seen with our data. So there's some work from the SEER database that looked at adequate cardiovascular imaging in patients. So the current recommendations are patients receiving cancer therapy should have repeat imaging during their cancer treatment to identify subclinical myocardial injury. Now, if you look at the adequacy of cancer treatment or imaging in patients with cancer, we see approximately 50% of patients do not have adequate cardiovascular imaging. Ontario data shows about a quarter of our patients do not have adequate cardiovascular imaging, and there's some data that shows that those patients who do not have adequate cardiovascular imaging are at a higher risk of cardiovascular toxicity. There's also a care gap. This is some data from Stanford that looked at cardiology referrals when patients have left ventricular dysfunction. Less than 50% of our patients were receiving cardiovascular complication. And Dr. Lee nicely showed yesterday there's an association between who sees these patients and eventual mortality. Less than 50% of our patients were getting beta blockers and ACE inhibitors when they have a reduction in left ventricular dysfunction. And this is even worse when these patients have asymptomatic LV dysfunction. I think we all know that asymptomatic left ventricular dysfunction is also associated with poor prognosis and cardiovascular mortality. So we have the perfect storm. We have shared risk factors, we have toxic therapies, we have a care gap, and this can potentially lead to what we've been talking about, which is the cardiotoxicity epidemic. So how do we prevent this? And I'm going to focus on heart failure because it's relevant to the symposium, as well as much of the data on heart failure prevention has in fact have been in the heart failure realm. I want to start off by first reviewing the stages of heart failure as it's relevant to the cardiotoxicity area. First is stage A heart failure. Stage A heart failure are those patients at risk. This may be diabetes, this may be hypertension, but in the cardiotoxicity area, these are patients who are receiving potentially cardiotoxic treatment. The next is stage B heart failure. These are patients who have some structural changes to their heart. This could be left ventricular hypertrophy in hypertension, or left ventricular dysfunction or diastolic dysfunction in diabetes. And in the cardio-oncology population, the focus has been on the reduction in left ventricular systolic function. And these patients are asymptomatic when they are in stage B heart failure. We can then progress to stage C heart failure, where we have symptoms, and stage D, where we have refractory symptoms. Thinking of patients in these categories is important because it has prognostic significance. If you look at patients in stage A and stage B heart failure, these patients have much better prognosis than those with stage D and stage D heart failure. So the general concept in the cardiotoxicity area has been to prevent progression from stage A to stage B heart failure, but perhaps most importantly, between stage B and stage C heart failure. So how do we achieve this? So there are two major concepts that have been used in the prevention of cardiotoxicity or heart failure, specifically in these patients. The first is if you're at risk for cardiotoxicity, if you're diabetic, you're going to treat diabetes. If you're hypertensive, you're going to treat hypertension. The only difference here is that, as opposed to diabetes, for example, where we do not know when the disease started, we know exactly when we are starting potentially toxic cancer therapy. So we can intervene by using drugs that can prevent the impact of that treatment on the myocytes. There have been two different approaches. The first is a mechanism-based approach, and one drug that has been studied is dexaroxane, which is an ion chelator and inhibits topoisomerase 2 beta. And what these studies have shown is that the initiation of dexaroxane prior to anthracyclines can prevent the development of cardiotoxicity. Overall, small studies, but convincing data. If we then, there's another concept that has been also devised in this area, and that's neurohormonal blockade. So no matter what the mechanism of injury is, you go through ventricular remodeling in heart failure. So there's a bottleneck of neurohormonal activation. Perhaps blocking at that bottleneck can prevent adverse remodeling in heart failure. So there have been several studies that have looked at ACE inhibitors and angiotensin receptor blockers, again, small randomized control studies that have shown that we can prevent the development of cardiotoxicity or specifically heart failure. But there's a caveat that data looks interesting, but the first thing is that dexaroxane has a black box warning at present, and the concern was that a higher incidence of hematological malignancies with the use of the drugs in the pediatric population. I think there's a lot more newer data that's going to refute this, and I think dexaroxane is going to become available, but this has been a concern in the past. And the second is neurohormonal blockade cause side effects in our patients. Our patients have nausea, they're vomiting, their intravascular volume depleted. Starting neurohormonal blockade usually results in a call from the patient to my office the next day saying that they're not feeling good. So what's the next approach? Perhaps we can identify in patients with stage A heart failure a slightly higher risk population and provide targeted treatment to these patients. And there are several characteristics that can potentially increase the risk of toxicity. This includes age, pre-existing cardiovascular disease, cardiovascular risk factors, your baseline left ventricular ejection fraction, and some treatment factors such as use of anthracyclines and tyrosine kinase inhibitors. But it's difficult to work with these individual risk factors, and what we're looking for is a risk prediction algorithm. But unfortunately, there are no risk prediction algorithms that are available that we can use in routine clinical practice. There's been an attempt to create algorithms based on some of the adjuvant clinical trials, but these have been quite basic. For example, here, just based on left ventricular ejection fraction and age, and does not account for the many other risk factors that we understand to predispose patients to heart failure. So that's dealing with stage A heart failure. The second approach has been to identify patients in stage B heart failure to intervene and to prevent progression to stage C and stage D heart failure. And the method that's been used is left ventricular ejection fraction. So patients are followed sequentially over time, and when there's a threshold fall in left ventricular ejection fraction, you would initiate cardioprotective therapy or neurohormonal blockage and hopefully prevent progression and hopefully revert left ventricular function back to normal. This data really comes from the 1980s based on MUGA data that has nicely demonstrated that if you do this, you can prevent progression to symptomatic heart failure. The question always has been, what is the best method to reliably identify a 10% change in ejection fraction? And MUGA scans are the ones that are most commonly used. But since echocardiography is also commonly used, we have looked at what is the best method by echocardiography to identify early myocardial injury. And amongst the different techniques available, we have identified the three-dimensional ejection fraction has the lowest longitudinal variability, allowing us to more reliably assess early myocardial changes. Despite this, there has been a concern about the use of left ventricular ejection fraction to identify early cardiotoxicity. And I think this was nicely shown by this work by Dr. Daniela Cardinelli from Italy, where she's looked at over 2,000 patients who have received anthracycline and has followed them meticulously over time with repeated cardiac imaging every 3 months and then subsequently every 6 months for approximately 5 years. What she has shown is that when you have a fall in left ventricular ejection fraction and you initiate evidence-based heart failure therapy in 2015, about 10% of patients will have complete recovery of ventricular function. 90% will only have partial recovery or incomplete recovery. And again, as I mentioned previously, we know that these patients can progress on to have symptomatic heart failure, and asymptomatic LV dysfunction is associated with increased cardiovascular mortality. So there's been an interest in looking for other markers of earlier myocardial injury. Candidates have been serum biomarkers such as high-sensitivity troponin I, which has been found to be useful. I won't focus on that here. The other method is myocardial strain imaging. This is a technique with echocardiography which measures myocardial deformation. It's a change in myocardial length between diastole and systole, and in several cardiovascular diseases, this has been shown to identify subclinical myocardial injury. So this technique has been applied in patients receiving cancer therapy. It's pretty easy. You get a two-dimensional image. There are semi-automated softwares that will provide you regional and global strain, and we can follow global strain over time, and a threshold change in global strain is suggestive of subclinical myocardial injury, and the strain changes occur even before a fall in left ventricular ejection fraction. There are several studies that have shown assessment of strain is better able to identify subclinical dysfunction than left ventricular ejection fraction. We have gone to summarize this data, and I've shown a threshold change in strain early during therapy, somewhere between 10 to 15%, without a fall in left ventricular ejection fraction, is predictive of subsequent LV dysfunction and heart failure. It has higher negative predictive value, however, than positive predictive value. However, we still do not know if we intervene when there's a fall in strain, can we change outcome? And that's the most important question. And this is the focus of our randomized controlled trial. It's a multi-center, multinational trial where we have randomized patients to two arms. One is a strain-based approach, and the other is an EF-based approach, and we are following patients over 3 years. These are high-risk patients, and we're looking to see if we can prevent left ventricular dysfunction and heart failure over follow-up. So hopefully I've shown you the spectrum here. A patient receives cardiotoxic cancer therapy, eventually has clinical heart failure. We have early markers of fall in strain and release of biomarkers. We have reversible left ventricular dysfunction, and then eventually irreversible myocardial dysfunction. But there must be a stage even prior to that. There must be a change to the myocyte that then results in some form of functional changes, whether it's deformation or ejection fraction change. And I propose, based on animal studies, that this is myocardial edema and myocardial inflammation. And we do not really have a good way, even by biopsy, to identify these two parameters. Can we do this non-invasively? Are there newer techniques that will allow us to do this? And cardiac MRI techniques such as T1 and T2 mapping will allow us to identify myocardial inflammation and myocardial edema. So this is the focus of our EMBRACE-MRI study, where we are following patients over time. These are women with HER2-positive breast cancer receiving anthracyclines followed by trastuzumab. We're imaging them with cardiac MRI, looking at these measures of myocardial inflammation and edema. Imaging is done prior to initiation of anthracyclines and multiple time points during their treatment. Our hope is to identify early signature of myocardial dysfunction, which will subsequently predict those who will have heart failure or left ventricular systolic dysfunction, with the eventual hope then again to intervene to prevent these adverse cardiovascular events. Here's an example of a patient in the EMBRACE-MRI study. This is a 51-year-old woman with left-sided breast cancer. I have imaged her multiple different times. Her ejection fraction by MRI was normal before we started therapy. Just after anthracycline, there was a small fall. She presented to me a month later with NYHA2 symptoms and a significant fall in left ventricular ejection fraction. And I was asking myself, could I have predicted that this patient will have a fall in left ventricular function at the second time point? So we looked at her MRI data. These are T2 maps. That's before she started therapy. Her T2 values were normal. The time prior to a fall in ejection fraction, she had a significant increase in her T2 values, suggesting myocardial edema and inflammation. She then presented with heart failure. We treated her with neurohormonal blockade. She had an improvement in symptoms. She had an improvement in her ventricular function, and the T2 values have come down. So the focus of the EMBRACE-MRI study is to look at genetic predisposition, cardiovascular risk factors, biomarkers, myocardial strain by echocardiography and MRI, edema and inflammation, with the hope of identifying the best predictor of subsequent cardiotoxicity. So given that, what should be some of our research priorities? And I borrow from some of the talks in the last couple of days to discuss some of the research priorities. The first would be to identify genetic predisposition. Maybe not to predict risk factors as presented by our first speaker yesterday, but perhaps to understand the pathobiology here. The second is to develop adequate risk prediction models, such as the Framingham Risk Calculator, where in our clinic, when we see a patient, we can put a set of numbers in and identify those patients at high risk so we can intervene to prevent heart failure. And most importantly, allow them to complete the planned cancer therapy. Because when left ventricular dysfunction occurs during cancer therapy is prematurely stopped, and that has adverse prognostic implications from a cancer survival perspective. The third is to understand some of the mechanisms of cardiotoxicity, and there are multiple different approaches. One approach may be to use human iPS-derived cardiomyocytes, and we're interested in looking at that. And this gives us the opportunity to potentially study mechanisms of prevention before this is tested in randomized controlled trials or other clinical trials. The next is we need studies where we have risk-based prevention strategies. And this is the focus of our SPARE heart failure trial, where we are randomizing patients. We're looking for funding at present. We are looking to randomize patients to statins and placebo to see if we can prevent the development of heart failure in patients at high risk of heart failure receiving anthracycline therapy. We also want studies that look at early intervention. We are focused on strain. Other markers such as biomarkers should be examined to see if we intervene and prevent the development of heart failure. We need to understand the rationale behind the care gap and provide education to promote equal care of patients and equal management of cardiovascular risk factors in patients who are cancer survivors. We also need to focus on survivorship care and risk factor management so we can prevent survivors of today becoming heart failure patients of tomorrow. So in summary, hopefully I've shown you that cancer survivorship is increasing. Cardiac toxicity is a key competing risk factor for morbidity and mortality in these patients. With the aging population, cardiotoxicity burden will increase significantly, and cardiotoxicity programs that are growing worldwide can provide a focused opportunity for investigations and interventions to prevent heart failure. There are many opportunities in this field for system-based interventions and innovative avenues to identify predisposition, identify mechanisms, to intervene, to prevent, and to intervene when left ventricular systolic dysfunction or other markers of myocardial injury are seen. And none of this work that I've presented would have been possible with a whole host of colleagues and support staff who has really helped us with some of the studies and who continue to help run some of the ongoing studies. I'd like to thank all of them. Thank you very much.
Dinesh, that was a fantastic review, and we have time for one question. Mansoor. We will have questions at the end, but we'll try to keep on track. Go ahead.
I'll just speak loud. Dinesh, first let me begin by congratulating. I mean, that was a beautiful presentation, really thoughtful review of all the factors and all the opportunities. And that's, I think you've single-handedly really captured what this meeting is all about, right? So I want to congratulate you. And I want to highlight that the Rogers Center has been in operation for barely 18 months. And your paper in Journal of Cancer Oncology is clinical oncology, is probably our third paper from the center, which I think is actually going to be very highly cited. It's a real achievement, so congratulations. My question is, following rapidly on the heels of Mikhail's talk, can you give us any insight? You mentioned that we share the risk factors, and you mentioned obesity in particular. What happens when you have diabetes and breast cancer and get chemotherapy? Yeah. Is it just like a nightmare?
Absolutely. I think that's a perfect question. So I think we've looked at risk factors for development of cardiotoxicity when patients are receiving highly toxic treatments. And the risk factor that has always borne out is previous history of diabetes and hypertension, and not surprising. There has been some controversy in the data, with some data suggesting that diabetes is not a risk factor. I think those are underpowered studies those studies have not had adequate events to capture the importance of diabetes. And hopefully with some of the population-based studies that we're doing, looking at 100,000 patients, where we can have adequate event rates. And ISIS is great when it comes to diabetes. We can capture diabetes in a relevant and appropriate manner at a population level. We should be able to show stronger associations between diabetes and cardiovascular disease in these patients. Absolutely.
Dinesh, on the heels of Mansoor's, I want to mention, because you had talked about this earlier with me, the issue of when the toxicity, the onset of the toxicity. Yeah. But if we really think of it as a multi-systemic issue, then you have again, the early toxicity from hypertension, obesity, diabetes, and then the insult. And I think there's a chance to synergize here with the other groups.
Absolutely, and also patients who have left ventricular dysfunction, who have had left ventricular dysfunction that has recovered, the development of diabetes or hypertension subsequently is a second risk factor that likely increases the risk of them having symptomatic heart failure in the future.